I'm Dr. David Ahlquist, a gastroenterologist and professor of medicine at Mayo Clinic in Rochester, Minnesota. And I was privileged to be a co-author on the manuscript recently published in the Proceedings entitled Stool DNA Testing for Screening Detection of Colorectal Neoplasia in Alaska Native People. Now, this was a study that targeted this special subset of our population, the Alaska Native people. They're important in many ways, but for the reason of this study, they have likely the world's highest rate of colorectal cancer. That is unmatched really any place in the world. And screening control in this population presents a real challenge in that over half of the population resides in communities, in roadless areas across this vast state, which is spreads out to nearly the size of the rest of the United States, looking at the miles between the extreme distances in the state. So what is needed is a screening tool that can be delivered easily to the patient, where access to some of the conventional approaches is problematic. The new stool DNA test was recently validated in a 10,000 patient study across the rest of the country and published last year in the New England Journal of Medicine. So the question was, would this tool perform equally well in the population of Alaska Native people? So we set up a collaboration between Mayo Clinic investigators and those at the Alaska Native Health Center in Anchorage. And we targeted 661 patients who were asymptomatic, ages 40 to 85, and pre-scheduled for either colonoscopy, screening colonoscopy, or surveillance colonoscopy. The stools were collected just prior to colonoscopy, which served as the reference standard. And the tests were sent to separate laboratories where there was no knowledge of the clinical setting, and it was completely blinded. So the findings were really striking in that they essentially corroborated those findings of the larger study that I mentioned, recently published in the New England Journal of Medicine. In this smaller study, there were just 10 cancers in the study, but all 10 were detected when the data were unblinded, so the sensitivity for cancer was 100%. For those polyps, and I might refer you to figure 2, those polyps that were at greatest risk for becoming cancer, those larger polyps, were the ones most likely to be detected. In fact, the trend of polyp detection by increasing polyp size was highly significant for the stool DNA test, but not for the fecal blood test, which we refer to as FIT. In all size categories of adenomatous polyps, the stool DNA test detected roughly twice as many polyps as did FIT. The subset of those polyps that we call sessile serrated polyps, these are primarily right-sided. They account for about 30% of all cancers. They are not hemorrhagic endoscopically, and they don't bleed. And in figure 2b, one can see that the stool DNA test detected about 67% of those polyps larger than 1 centimeter, compared to just 11% by FIT. Quite a striking difference. There were relatively few numbers, so the p-value did not quite reach significance, but the absolute difference was striking. I'd like to refer you to figure 2c, where we compared the false positive rates between the two tests across age ranges. There was a significant increase in the false positive rate with older ages for FIT, but not for the stool DNA test. Overall, the false positive rate was about 7% for the stool DNA test and 4% for FIT, and that was a significant difference. And then moving to figure 3, how do these data, how do they impact a test of effectiveness or efficacy? And as you can see in figure 3, roughly twice as many tests are required in screening a population to detect one screen-relevant neoplasm by FIT compared to stool DNA testing. Stool DNA testing is a much more efficient way of culling lesions out of a population. And then finally, I'd like to refer you to figure 4, which looks side by side at the main outcomes of this study in Alaska Native people with that larger study of 10,000 patients across the rest of the country. And as you can see, the results for polyps at different size categories and cancer are virtually superimposable. The subset of polyps larger than 3 centimeters, the sensitivity was 80% in the Alaska study, slightly lower than that by a tad in the larger study, and for cancers 92% versus 100%, very high rates. Those are rates that have been described for colonoscopy sensitivity. This is a non-invasive test. So, where do we go with this? What are the implications? First of all, as you saw, the results corroborate the performance of the much larger study in this special population at very high risk for colon cancer. But secondly, what's important in a screen application is how the test works over time within a program. What we evaluated was how the test worked at one point in time, so-called cross-sectional analysis. The Center for Medicare and Medicaid, CMS, has approved the stool DNA test at an interval of every 3 years. And when one applies that to a population model, the sensitivity for a polyp in the category of 2 centimeters and larger is over 90% by the second screen. For polyps 1 centimeter and over, it increases to 90% by the third screen. You can't rely on serial screening for colon cancer because it progresses quickly when it is in that stage. You need high sensitivity right out of the blocks, and with 100% sensitivity in this study, that the stool DNA accomplishes that important, critically important performance characteristic. And I would just make one last comment, and I think I know our investigators, our co-investigators from Alaska would echo this. Seeing the performance characteristics of stool DNA testing in this population raises hope that this can be a tool that, when applied regularly across this population, done by Mayo, this could have a serious impact on both the morbidity, mortality, and incidence of colorectal cancer, which is such a killer in this group of people. So thank you very much.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.